Indonesia, Commission on Population Philippines, General Office for Population and Family Planning Vietnam, Ambassador for Tunisia, Seychelles and Australia, Asian Population Association Council members, Johns Hopkins CCP, UNFPA representative, and other development partners, universities, civil society organization, media, ladies and gentlemen. Good morning from Jakarta, Indonesia. My name is Irma, Head of Center of International Training and Collaboration, National Population and Family Planning Board, BKKBN, Indonesia. Hope you and your family are healthy and safe during these uncertain and unprecedented times. As one of PPD member countries, we are more than happy to welcome all of you in our first webinar 2020 with the theme COVID-19, Public Health and Economic Perspectives. The webinar is collaboratively hosted with Johns Hopkins CCP. On behalf of Government of Indonesia and people of Indonesia, we are extending our deepest condolence to the government and people of Bangladesh at the sudden and sad to miss Honorable PPD Board and Executive Committee member. Our deepest sympathy during your time of loss, our thoughts and prayers are with you during this difficult time. And today, we are going to learn of the success story of Indonesia, focusing particularly on how we can possibly sustain family planning program in recognition of our continued support to PPD member countries, our commitment for Family Planning 2020, and our commitment to end 3 zeros, including unmet need for family planning. We also invite experts from Johns Hopkins University and University of Indonesia to share coping strategies across countries in terms of family planning and reproductive health during COVID-19 outbreak. The uncertainty and decline in travel will also lead to people staying home from work, losing income, and possible causing a fall in demand for family planning. A recent report from the Indonesia Statistics Agency highlights that the poor, vulnerable, and those working in the informal sector are the most affected subpopulation. Experts from the Asian Population Association and Australian National University will discuss these issues related to demographic point of view. Now, I invite the Honorable Chairman of BKKBN, Mr. Hasto Wardoyo, to give a warm welcoming remarks.
Thank you, Mr. Irma. Good morning, everybody. Assalamualaikum warahmatullahi wabarakatuh. Your Excellencies, Ambassador, Ministry, and Head of Institute of Friendly Country, Partner in Population and Development, PPD, Board and Executive Committee members, distinguished guests, Mr. Adnan bin Haj, Executive Director of Partner in Population and Development, Head of International Development Partner UNPA, and Johns Hopkins Center for Communication Program, and ICO MP, Partner Country Coordinator of PPD, and Professor Arsananta, President of the Asia Population Association, Professor Kevin Jones from Australian National University, and Bapak Iwan Aryawan from Faculty of Public Health, University of Indonesia, Ms. Utara Parakumar, Senior Technical Advisor Social Behavior Change and Capacity Strengthening at Johns Hopkins Center for Communication Program, Professor Damane from Deputy of Training, Research and Development BKKBN Indonesia, and Pak Rob, Senior Technical Advisor, John Hopkins University Center Communication, and my colleague from BKKBN University Academia, participation of webinar, ladies and gentlemen. First, let us thank the God, His blessing and the allowing us meet today in this webinar. On behalf of National Population Family Planning Board of Indonesia, BKKBN, I would like to thank all of inviters for joining in the webinar. I also would like to congratulate the organizing committee for making this seminar by virtual technology and web seminar have become a new normal for all of us. Excellencies, ladies and gentlemen, I believe I'm not alone to saying that COVID-19 is the most powerful health crisis of our time in the last 10 decades. And today, one again, a virus pandemic that is COVID-19. Then it was first identified for Wuhan, China, and declared in the global pandemic and public health emergency of the international concern by World Health Organization on January 30, 2020. The number confirmed has continued to increase. In Indonesia, the number of confirmed cases by 20 June 2020 has reached 45,000, resulting in the more than 2.4 thousand deaths. Excellency, ladies and gentlemen, the Indonesia government has taken policy to respond the COVID-19 pandemic. In March 2020, Indonesia declared the status of this disease to be an emergency response state. The government of Indonesia issues President Decree number 7 2020 concerning to task force for acceleration of corona response effort. Led by head of National Disaster Management Agency, in Indonesian name is Badan Nasional Penanggulangan Bencana, BNPB, the task force aim to improve the national resilience in health sector and to accelerate response effort of synergizing coordination and cooperation with all of ministry, institution, and local government to increase anticipation of the acceleration of spread of COVID-19 and to increase synergy of operational policy making and to increase readiness of ability to prevent, detect, and respond to COVID-19. And the large-scale social restriction, bisa by pembatasan sosial berskala besar (PSBB) are implemented by some local government. It allow local government to restrict the movement of people in and out from their respective area. The people were also prohibited from going home to celebrate of Eid Fitr. And recently, Indonesia began to achieve its social restriction and has now entered to transition phase. Excellency, ladies and gentlemen, we are in the midst of unprecedented time. An infectious disease has profoundly changed the way we live. It touches every single aspect of our life, not only in the area of public health, but it is also the social and economic aspect. The uncertainty of social restriction may affect of our effort for realizing of Indonesian demographic dividend. Job creation and ability of the labor market to absorb the labor force are key factor in the utilization of the demographic dividend. So the COVID-19 outbreak also has been profound impact on access to family planning and sexual reproductive health services and information. Every country family planning and reproductive health program has been struggling to ensure that family planning and reproductive health services are in place. Ladies and gentlemen, excellencies, so today webinar is conducted to commemorate Indonesia Family Day with a celebration annually every 29th of June. Also coincided with the 50th anniversary of BKKBN. So in the time, we would like to share with you the good practice and the management of population, family planning, and family development program. And the last, BKKBN with the new motto, BKKBN with the new approach, the new spirit present in your family. BKKBN in collaboration with Asian Population Association and the John Hopkins Center of Communication Program is elected to host this webinar with the title COVID-19 Public Health and Economic Perspective. We do hope in this moment, this virtual seminar enable us to share and learn from experts who bring the variety point of view of experience. So, thank you and stay healthy. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Mr. Chairman, for welcoming remarks. In commemorating 27th Indonesia Family Day and 50th anniversary of BKKBN in safeguarding population and family planning program in Indonesia, please allow us to have 3 minutes of your time to see BKKBN landmark until present.
Everything starts from a plan. To develop a country, build a prosperous family. It's been 50 years we've dedicated our service to prosperous families all over Indonesia, providing the best services and programs, from the remote cities through the central, not only to maintain the population growth, but also giving our full contribution to development of a planned family. We always prioritize development that focuses on population. Organize the family planning and the people's reproductive health. Develop our partners in organizing the population issues and the importance of development within the family. And also to apply a consistent work culture. A developed country starts from you, who grew a family full of love. Creating courteous, devoted, and high-achieving individuals. When millions of plans have to be delayed and thousands of families suffer, a lot of people have struggled, but they lost from the situation, and many have been slammed down. Those who are close become far. There is no safe haven. Around you are many failed plans. Many families could not return, and many have been left behind. When the situation makes us remember, where is the place we should return? Only one thing: follow the heart. We will always be with you. Rebuild the plan, walk together to reach your ultimate goals. It starts from the family. Every family in this country, without exception. We will always be there and give our best service to be a better country and reach the highest goal. Together we rise, relieve the pain. Don't give up now, because you are the strongest human being. Know yourself, rebuild your plan, move forward, look into your family. Together with BKKBN.
Come together, we're all family.
Well, it's quite inspirational. Now we're coming to the session. It will be moderated by Rob Ansley from John Hopkins Center for Communication Program. I think, Rob, time is yours.
Thank you very much. Good morning, afternoon, and evening, depending where you are in the world. To the Honorable Pahasto, Ibu Irma, the distinguished participants and guests to this webinar. My name is Rob Ainsley and I will be moderating for today's session. I'm quite excited to be a part of this webinar today and that we're looking at public health and the economic implications of COVID-19 pandemic here in Indonesia as well as in other countries of the world. First, I'd like also to say congratulations to BKKBN for 50 years, for your 50th birthday and for 50 years of great performance here in Indonesia. So today we're going to have three panelists and three presentations. The first one will be from Professor Rizal Damanik, the second from Professor Aris Anata, and the third from Ms. Uttara Barath Kumar. After those presentations, we have two discussants that will be Professor Gavin Jones and Pa Iwan Ariwan. They will provide perspectives and feedback on the presentations to inspire our discussion going forward after the discussants. After the discussants finish, we'll be followed by a question and answer session. We will hold all questions until the end of the discussant period, and all questions should be put in the chat box, the Zoom chat box. We'll be getting the questions from there and asking those, presenting those to the panelists. So without further ado, I would like to introduce our first panelist. Our first speaker of the day is BKKBN's own Professor Rizal Damanik, PhD, who will be presenting on Indonesia's strategy to sustain family planning program during COVID-19 outbreak. Professor Rizal Damanik is currently the Deputy for Training, Research and Development here at BKKBN. He is a professor of community nutrition at the Bogor Agricultural University in Indonesia. He received his PhD in international health and human nutrition and a master's in reproductive sciences from Monash University in Australia, as well as he's a doctor of veterinary medicine from IBP University in Bogor, Indonesia. He has been a professor and lecturer at a number of universities here in Indonesia and internationally. His area of specialization is nutraceutical, functional food, and nutrition for pregnant and lactating women. Please, silakan Professor Damanik.
Thank you, Rob. Just a second, I would like to share my file. Can you see my file? Sorry. Can you see my file, Rob?
Yeah.
Hello?
Yes,
Okay, Prof.
Okay.
it's not in presentation mode.
Okay.
I think you can continue.
Okay. Thank you. So thank you, Rob. Your Excellencies, Dr. Hasto Wardoyo, the chairperson of National Population and Family Planning Board, or BKKBN. Our distinguished speakers, Professor Aris Ananta, the President of Asian Population Association, Ms. Uttara Bharat Kumar, a Senior Technical Advisor in Social Behavior Change and Capacity Strengthening, the John Hopkins, CCP, and our distinguished discussants, Professor Gavin Jones from the Australia National University in Canberra, and Dr. Iwan Aryawan from University of Indonesia here in Jakarta. Ladies and gentlemen, Assalamualaikum warahmatullahi wabarakatuh. First of all, I would like to convey our great welcome to you to join in the International Seminar on Public Health and Economic Perspective of COVID-19. And my presentation today entitled Indonesia Strategy to Sustain Family Planning Program during the COVID. Ladies and gentlemen, a global, national, and regional authorities have been pushed to immediately have appropriate preventive control and mitigation measures in place due to the COVID-19 outbreak. Every country has mobilized its resources to ensure that the parachute is working properly. It requires timely data and information as well as evidence on behavioral and biomedical intervention during and after the outbreak. We note that the world's population is expected to increase by 2 billion persons in the next 30 years, growing from 7.7 billion in 2019 to 9.7 billion in 2050. 9 countries, including Indonesia, will make up more than half of the projected growth between now and 2050. It is still premature, if I may assume, that the outbreak may disrupt the global population projection. However, we have observed here in Indonesia that women are refraining from visiting health facilities due to fears about COVID-19 exposure or due to the restriction on movement and the potential of supply chain disruption limiting the availability of contraceptives in many places. Difficulty in assessing quality health care may acutely challenge the progress of a country's ability to achieve better health outcomes. Inaccessibility to family planning services, particularly in Indonesia, poses a threat for increased discontinuation rate contraceptive and unintended pregnancy. Globally, 47 million women will be unable to access modern contraception. 7 million of them will experience an unintended pregnancy, and 31 million gender-based violence cases will occur if the average lockdown countries for 6 months in 114 low and middle income countries. The COVID-19 pandemic has exposed the susceptibility of our public health system. The spread of the virus is non-discriminative, yet low-income workers, people living in slums, urban areas, especially women and girls, migrants and refugees are the most vulnerable in subpopulation. Indonesia has put in place strategies to cope with the situation. It emphasizes the provision of accessible information, continuation of family planning services, and contraceptive security. The information is massively promoted through online media with 2 main messages. postpone pregnancy, and maintain the use of contraception. Under BKKBN, John Hopkins CCP partnership with USAID support, we designed a massive penetration of family planning information from 15,000 family planning field workers to approximately 1.3 million carers throughout Indonesia. The design optimizes the use of ICT platform and is expected to cover millions of Indonesian families. The content of information is in line with the messages developed by National Task Force in terms of COVID-19 prevention. Widen family planning service focus to reach underserved groups in areas with high unmet need, including the poor and those with no health insurance. In collaboration with 500 local governments, we want to ensure that the distribution of contraceptives from municipality or district warehouses to 18,000 health facilities is in place according to its resupply planning. An innovative community-based supply chain mechanism utilizing family planning field workers have been introduced to provide contraceptives directly to eligible couples in need. We are grateful to local governments and Indonesian Midwife Association for their persistent commitment to educate and provide family planning services in the current situation. As such, we do hope family planning will be able to break the intergenerational poverty that might be accelerated by the pandemic. Having amended to manage family development program, the outbreak has created at a certain point the opportunity for BKKBN to strengthen Indonesia family endurance. By staying at home, there are many productive activities can be done by family members together. We also engage them to provide life-saving information to other families in addition to family planning messages. To commensurate the Indonesia Family Day 2020, we want to nurture our families' days. We want to ensure our family values to be stronger and adaptive to current situation with the spirit of new spirit, and I'm sure that we are able to share and learn new and adapted information and knowledge. It becomes our valuable asset to collaboratively alleviate the devastating impact might arise. So with that, I think that's enough. Thank you very much, Rob.
Thank you very much, Professor Damanik, for that nice overview of the challenges that are being faced by women and their partners here in Indonesia and globally with the possible through lockdowns and possible challenges women will have to continue receiving their contraceptive methods and getting ways to be seen at the facilities. And also what are the strategies being put in place by BKKBN and others here in Indonesia to help mitigate those problems, whether it's through supply chain management activities at the community level, working with local governments, and also still moving and promoting the message of family planning, the importance of family planning, so that women have what they need and the information they need, but also where they can access those services. So thank you very much, Damanik, and again, for bringing to our attention the Family Day here in Indonesia, which is June 29th, and we'll be having some celebrations across the country for that. Probably distancing, social distancing, of course, no hugs and handshakes. But thank you very much, Damanik. Our second speaker is Professor Aris Anata, PhD, who will be presenting on economics, demographic perspectives of COVID-19. Professor Aris Anata is an economist demographer with a multidisciplinary perspective. Currently, he is Professor of Faculty of Economics and Business, Universitas Indonesia, and adjunct researcher at the Demographic Institute at the same university. He is also a visiting professor at the Center of Advanced Research, University Brunei Darussalam. He is president of the Asian Population Association in the term 2019 to 2021. Previously, he was Senior Fellow at the Department of Economics, National University, Singapore, from 1999 to 2000. Senior Research Fellow at the Institute of Southeast Asian Studies, Singapore, from 2001 to 2004. And during 1983 to 98, he was occupied with teaching, research, and managing academic institutions at Universitas Indonesia. He speaks Indonesian, English, and Javanese. Please, Prof. Aris, silakan.
Yeah. Thank you very much, Pak. I will share my PowerPoint. Can you see my PowerPoint?
Yes.
Okay. Thank you very much for everybody. Thank you very much for the moderator. And thank you very much for the BKKBN for inviting me to give a presentation for this time. I am a little bit confused because there is always notification coming. Administrator, can you stop notification to me? Okay.
The chat off.
The administration, because I am included as administrator, so there is always notification coming to me. 3 people entered the waiting room for this meeting. This is blocking my PowerPoint. Okay, the topic of my presentation is economic and demographic perspective of COVID-19 Indonesia. COVID-19 is something new for everybody in the world. Everybody is learning about this COVID-19. So it is new and complex issues. What I present is what I have been learning for this time. The COVID-19 is still very new, and I'll share a little bit what I knew. And my presentation is based on Indonesia as background, to hopefully it will be applicable for other countries too. Because this webinar is initiated by BKKBN, I will also discuss one of the mission of BKKBN, that is on family resilience. Sorry, it doesn't work for the slide. Maybe stop the notification.
No, it's on yours. You should be able to. If you see the small, I think it's in the left-hand corner, where you can see. Hold on. Yeah, it's on the left-hand corner. You'll see an arrow. You can press that arrow. That should move the slides. Do you see it on yours?
This, okay. Okay, yeah. Okay. Yeah, this presentation is only a small part of the issue. Okay, this is the outline of my presentation. There are 4 points I would like to discuss. First is whether there is any trade-off between health and economy. The answer is that we can have a win-win solution with new normal, plural, because there are many new normal. The question is whether health or economy, is there a trade-off? What I like to present is that we don't have to have a trade-off. We could have a win-win solution. Next to that, I will talk about how to build family economic resilience. Here, I will provide some practical recommendation to be healthy and able to earn money for the families. The third point is demographic dividend. This is a trendy topic in Indonesia. Almost everybody, whenever they're talking about population issues, they always talk about demographic dividend. Here, I will like to present an alternative view to the demographic dividend. Fourth point is that what should BKKBN do? In terms of contraceptive, is understanding that contraceptive is one of people's basic need and human right. Creating awareness among couple that they, especially women, have the right not to have children or to determine how many children they want and when. About fulfilling unmet need of contraceptive use and promoting long-term contraceptive. Second issue is population mobility. BKKBN is not only about family planning, but population issue in general. So it has to talk about population mobility, understanding right to move and not to move. The third point is aging population. It is understanding the rights to live decently at all ages. This is benefiting not only for the currently older person, but for everybody, because everybody will eventually become old. The first point, is there any trade-off between health and economy or business? People always ask this one, should we die because of the COVID-19 or should we die because we are hungry? It seems that health and economy can be separated. My answer is that not necessarily. With new normal, we can improve both health and economy. The new normal is a solution and we have to work on it. This is a simplified model of the health and economy, a model of a closed economy without monetary sector. From this diagram, you would see that how health impact the economy through the labor, through the state budget, production, demand, but eventually the economy will affect health. Without economy, the health sector cannot go, cannot treat the people. But without health, people cannot work. Without health, the government will not have the money and no income, no production. So health economy is very, very related. We cannot separate one from the other. If we don't care about health, the economy will collapse. If we don't care about the economy, health will collapse too. So with this simple model, I like to show that health and economy are not two things which can be differentiated. They are both very closely related. We can improve both the economy and health by creating new normal. We have to be able to live with COVID-19. Before the COVID-19, we already hear about the arrival of disruption era. The future will be very, very different today with the new technology arriving, new norm, new behavior, new way of life. And the COVID-19 has accelerated the arrival of disruption era. What are new normal? Many people have been talking, and we should be aware that COVID-19 can be around us for a long time. Do not expect or wait for the return of the old normal. We will be frustrated if we are waiting for the old normal. We have to live with the new normal. We have to innovate. We have to create new job and behavior which are safe from COVID-19. Business who can work with the new normal and create new normal will be profitable during this time and the future. Those who cannot create and follow new normal will suffer economically and also in terms of health. We have to generate healthy and environmentally friendly lifestyle, make us immune better in facing the COVID-19. We have to create more effective screening tool to enter public space. Yeah, we have to do this one too. Now, second point about how to build family economic resilience. This is a derivative of what we talk about new normal in the general thing. I realize that family economic resilience is related to community and state economic resilience and individual economic resilience. But here, I focus on family economic resilience because of the time constraint, and this is one of the focus of BKKBN. This is a simplified model on the relationship between family, individual, state, and community, but I will focus more on the family. It is resilience, is ability to bounce back. When we fall, how fast we could return to the previous condition, or better or worse. The next issue is sustainability. When we go down and then we go up again, whether we will go down again. Sustainability means once we go down, we could go up again, go down, go up again. That's resilience. Hopefully we will be up in the longer term. Some practical recommendation: be healthy. Being healthy meaning that we could, being sick means more expenditure. This is the relationship. If we don't care about health, that means that we have to spend more thing for being sick. So from economic point of view, this is not very good. So being healthy is good in terms of economic. By being healthy, we can create innovative economic opportunity. So we have to apply healthy and environmentally friendly lifestyle from now on, and create jobs that can protect our health, including working from home. Next thing is that we have to be digitally literate. We have to innovate jobs which use more advanced digital technology. If we don't follow, if we are not digitally literate, we will be left behind. This is the arrival of the disruption era. If you have to go out to earn money, protect yourself from the virus. We also, if we lost our job or we suffer from income cap, then we live in the uncertain prospect. What should we do? Yeah, we have to minimize unnecessary spending, buy only basic need. In the uncertain time, reduce buying durable goods, choose cheap and healthy food and drink, cut consuming fried food, sweet and salty food. For my friends from outside Indonesia, I need to mention that fried food, sweet and salty foods are very delicious in Indonesia. So we have to cut this one. Cut smoking, cut consuming meat, increase consuming fruit and vegetable, drink plain water, reduce drinking canned sweet drink. This is just some example that we have to spend only for the basic need. This will make us healthier and having more financial reward, financial reserve for the uncertain time. There can be many other examples, but this is just some example that health and economy can go together. This is some monetary policies that can be used to increase household or family economic resilience. Reduce or cut administration fee for small account holder. Many of us sometimes complain that administration fee is too high. Maybe this is the time during COVID-19 to reduce administration fee so that small account holder can have more saving to face for uncertain time. Perhaps interest rate can also be increased for small deposit. This will help people with low income have more preparation to face for the uncertain time. Perhaps erase tax. We don't have to tax interest for small account holders. This is supposed to help low income people to save more. Third point is demographic dividend. I like to present an alternative view. Everywhere, as I mentioned earlier, talk about demographic dividend, but I heard many people complain they don't understand what is demographic dividend. In Indonesia, it is often heard as demographic bonus demography. They ask whether we could memetik demographic dividends, when and how. So I like to present an alternative view of the demographic dividend. Some people say demographic dividend, demographic bonus, or window of opportunity. The three words to me is interchangeably, but some people attempt to distinguish them. So this is one example that we don't have an agreement with about the three of the term, but most of the time they are interchangeably. This is an old debate and a new package. Which one is better, big or small numbers of population? Whether big number of population is good for development, whether small numbers of population good for development, this is an old debate beginning since about 200 years ago. The answer for that time is that big or small doesn't matter for development. The most important thing is the quality of the population. What is the policy implication of existence of demographic dividend? For those who believe on the demographic dividend, they have some policy implication. One is strengthening the family planning, continuing the family planning. Second, improve education and health. Third, create productive employment opportunity. Four, opening the trade, export, import, good governance, and so on and so on. The question is, if we do not have demographic dividend, should we make these policies? Should we strengthen family planning? If we don't have demographic dividend, should we improve education and health? Should we create productive employment opportunity? Should we open trade? Should we create good governance and so on? The answer is, of course, yes. Even when we don't have demographic dividend, we should strengthen family planning, we should improve health, we should improve education, we should create productive employment opportunities, we should open trade, we should construct good governance, and so on, even without demographic dividend. There is nothing new. There is nothing new in the policy implication. We can produce the same policies even when there is no demographic dividend or bonus. Demographic dividends, there are some measurement problem of demographic dividend. The demographic dividend is based on the concept of dependency ratio. That is, DR is population under 15. Population under 15 plus population above 64 divided by population 15 to 64. Why do they use this ratio? This is formula I learned since the beginning. I was studying demography and economy long time ago. And the assumption is that people under 15 years old are unproductive, burden. So if you have children under 15, your children are burden for you. This is the assumption of the concept. Why 15? Why not 25? People now going to school to finish their tertiary education. So maybe we can use 25. But is that correct that children are burden for us? Children can be source of happiness for us, and children can enhance parent productivity. So this is problematic for defining below 15 and even below 25. Are children really burden for us? 64 and above, they say they are unproductive, burden. Is that correct? In Indonesia, many people above 64 are still working, they're still contributing to the economy, they are taking care of the grandchildren, so helping the children to work. Another thing is that why not 60? The definition of older people in Indonesia is 60 and over. Next is the definition of 1564. It's assumed to be productive, it's unsaid. But the question is, how is their quality? How is the health status? How is the education, skill, and income of 1564? If they don't do anything, if they cannot work, if they are not healthy, they are not productive. In Indonesia, working age population is population age 15 and over, not 15 to 64. No upper limit of working age population. This is a recognition that being old is not necessarily a burden, that people 64 and over can still contribute to the economy. Thank you, Statistik Indonesia, Badan Pusat Statistik, for making this definition. When dependency ratio is below 0.5, They said that 100 productive person has to support only less than 50 unproductive person, quote unquote. That's what they said. This is the so-called demographic dividend or bonus. The dividend or bonus will disappear after dependency ratio reaches above 15, about 0.5. It is not clear why the threshold is 0.5. Why not 0.6? Why not zero point 0.4 or other numbers? With a different threshold, we will have a different result. Sometimes people define demographic dividend starting from the lowest dependency ratio below 0.5. It is neither clear why it starts from the lowest dependency ratio. Now there is another term, demographic window opportunity. Some argue that this opportunity happens when the percentage of population aged below 15 is 13% and the percentage of population aged above 64 is 15%. Others mention that this opportunity happens when the median age of population is between 26 and 41. In short, there are so many different measurements of demographic dividend, demographic bonus, and window of demographic window opportunity. This is a substantive issue of the concept of demographic dividend. The model of demographic dividend says that when the percentage of the dependents are small, people can save more. With more saving, people can do more investment. More investment means more economic growth. This is the argument by Ainsley and Cole in the late 1950s. But this model is too supply oriented. The orientation is on the supply side only. It forgets that a large number of children can mean a large household consumption, which increase aggregate demand and therefore promotes economic growth. So the first one is that the model of demographic dividend is too supply oriented. They forget about the demand side of the economy. Second issue is that the model forgets that investment does not have to depend on saving only. People may not have saving, but people can borrow money from the bank. We can have foreign direct investment. So that the assumption that investment comes from the saving of the people only maybe have to be relaxed. Investment can come even when we don't have saving. Another problematic weakness of the concept of demographic dividend or bonus is that the concept is too oriented to economic growth. The orientation is economic growth, economic growth, economic growth. I'm not anti-economic growth. We need economic growth, but economic growth is only a means, not the goal of development. Our goal is not sustainable development, which is beyond economic growth. Sustainable development includes social and environmental aspects, including health and environment. Using sustainable development as our goal, there is no conflict between health and economy. But if we talk only about economic growth, there can be sometimes conflict between health and economic growth. The next issue is problem with the concept of productive. Productive is assumed to be only related to age. However, productivity depends on many other things. Productivity depends on health, education, ability to move, freedom from fear, as well as social, political, and economic environment. So this is an alternative view of demographic window opportunity, demographic dividend or bonus. The window is open when people have quality education, excellent health, ability to move and not to move, freedom from fear, decent employment, regardless of age and sex, for whoever they are, young, old, middle age, below 15, above 64, 15 to 64, men or women. The window is open when we have quality education, excellent health, ability to move, not to move, freedom from fear, decent employment. This is also regardless of number of population. Number of population can be big, can be small. Window is open when people have quality education, excellent health, ability to move and not to move, freedom from fear, and decent employment. The last point is about policies for BKKBN. Prof. Damanik already talked about contraceptive. I will just mention some recommendation. We have to return the non-COVID-19 services. So far, we have been concentrating to the COVID-19 services, but non-COVID-19 services are also important, including contraceptive use. Contraceptive is one of basic need and human right. So when we help low-income people for food, drink, and shelter, we forget that contraceptive is one of the basic need. In Indonesia, we know about the sembako, 9 bahan pokok, 9 basic need. That 9 basic need has not included contraceptive use. I think the basic need in Indonesia should be broadened to include contraceptive use. Contraceptive use is one of people's right to have access contraceptive use. We need to focus on unmet need. There are many people who want to use contraceptive, but they cannot. And we should give priority to long-term contraceptive. This is cheaper. And I hope business will be interested too to provide long-term contraceptive. More recommendation for population policies. BKKBN is not only about contraceptive, but also the whole population issues. Again, from contraceptive, we have to give more attention to the surface of contraceptive use, as this helps fulfilling human right. Contraceptive use is help fulfilling human right. And we need to utilize the COVID-19 as a momentum to build economic resilience by being healthy and environmentally friendly lifestyle, including having reliable access and affordable to contraceptive. BKKBN also help people building readiness to create and follow new normal. Some people are not ready, so BKKBN can continue working to help people ready to create and follow new normal. Forget about the old normal. BKKBN may also promote social responsibility to prevent the spread of the virus. This is not only the responsibility of the government, but for the people at large. Are we aware of the risk? Are we having social responsibility to prevent the spread of the virus? It may be uncomfortable. Some people said to me, Paris, using new normal is not comfortable. But this is the only choice to strengthen the economic resilience and stopping the spread of the COVID-19. We are sick. Being sick is not comfortable, but we have to take this one if we want to strengthen the economic resilience and stopping the spread of the COVID-19. If we don't want to follow and create new normal, economy will collapse, health will collapse too. A life cost approach, typing error, BKKBN should continue to use a life cost approach since people are still in the womb until they are in the tomb, the whole life cycle. Therefore, this approach should include attention to, in addition to contraceptive, BKKBN should also pay attention to the population mobility. Population mobility is people have the right to move and not to move. And people should have the right to have decent life at older age. Should people work for money until they die? We may talk about that everybody will become old. Just think, when we become old, should we work for money until we die? This is the summary of my presentation. 4 points. One is that any trade-off between health and economy, not necessarily. We could have both, improving the health and improving the economy. The only way is creating and following new normal in plural. Now is the time to create new normal in every activity, economic and social activity. One of my friends said, it's not new normal, it's new norm, norma-norma yang baru. Well, we could also debate this interesting suggestion, but we could discuss that later. The main point is that everybody should forget to return to the old normal, because we will be frustrated if we are always dreaming about old normal. We are coming to the new normal, creating a new normal, following new normal. This will be a win-win solution for our health and economy. How to build family economic resilience is the derivative, the same thing with the new normal. During this uncertain time, spend only on basic needs. Work to earn money by protecting ourselves from the virus. It's not nice, but this is what we should do. We don't know until when we will have the virus. We don't know when about the future. So we have to protect ourselves. Spend only on basic needs. Third point is demographic dividend. The same policies can be produced with or without the existence of demographic dividend. And there are also many measurement and substantive problems with the concept of demographic dividend. What should BKKBN do? In terms of contraceptive, understand that contraceptive is one of people's basic needs and human rights. We have to continue creating awareness among people, among couples, that they, especially women, have the right not to have children, have the right to determine how many children they want and when, have the right to pursue their career. BKKBN also need to continue fulfilling the unmet need of contraceptive use, to reduce unmet need of contraceptive use, and to promote long-term contraceptive, which is cheaper. And also, another area of population issue is population mobility. We have to understand this, as mobility is one of the human rights to move and not to move. We have the right to move and we have the right not to move. This can be another webinar topic. Another webinar topic which should be attention of BKKBN is aging population. Everybody will become old, but when we are old, should we work for money until we die? Do we have the right to live decently at all ages? I think that's all what I like to present. Thank you very much.
Thank you very much, Professor Aris, for a very interesting and deep look into some things we're dealing with now in the COVID era. First, looking at the new normals in ways that we haven't started thinking about it. We've been usually thinking of new normals. What's it mean for new behaviors? You're looking at it as what are the new opportunities to take with new normals, and maybe is that something that might be take advantage of those, and something that might be a new reset when we look at going forward in the new normal, as they say. But you're saying new, and I think that's an interesting way to look at it. Also looking at family resilience and looking at the recommendations that families can take on how to get through these times, and really are good behaviors. Looking at healthy behaviors, what you can do to improve your health, and looking at how you take advantage or how you can get through if you're at an economic disadvantage in these times. And I think going back to the health, there's always that one phrase we say, health begins at the household, and what can you do at the household to start your healthy lifestyle? And then I think on the demographic dividend, it was a refreshing new look at the demographic dividend and looking at it more in a humanistic way and what it means only in what you were saying, a supply side, but there's a lot of other aspects of the demographic dividend to look at. Specifically, what are the windows of opportunity, and would you do this anyway if there wasn't a demographic dividend? These are good policies, good recommendations for any government to take in improving education, improving health, improving skills. So whether you have the demographic dividend or not, you still would be going down that route. And then the demographic dividend gives you an opportunity to maybe take a little more advantage of that, but also looking at why be constrained within that the DR ratio and looking at only under 15s over 64. So there's a lot to look at, and maybe in these, how COVID affects that, we might be relooking at that demographic dividend in the short term and the long term. And also recommendations for BKKBN on how to move forward. And really, I think coming out of that family planning is a human right. And I think that most all of the programs globally, especially here in Indonesia, does look at family planning as a human right, and how to make sure women have a continuity to services and methods. So thank you very much for the insight, Prof. Aris. We're going to go to our third speaker today. is Uttara Bharath Kumar, who will be speaking on family planning, challenges and coping strategies across countries, taking more of an overview look at a number of countries. Currently, she is the Senior Social and Behavior Change and Capacity Strengthening Advisor on the USAID Global SBC flagship program, Breakthrough Action. She has been with the Johns Hopkins University Center for Communication Program since 1997, based in Baltimore, Zambia, and India. She is currently based in Chennai, India, providing regional technical expertise and support to programs in Asia and Africa. She has led communication programs and initiatives globally involving multiple health areas, including HIV, AIDS, STIs, maternal and child health, family planning, nutrition, malaria, tuberculosis, and cancer. Some of the initiatives she spearheaded have won awards: the Red Ribbon Award 2006, Silver Medal at the New York Film Festival 2007, AfriComet Award for Best Multimedia Media Campaign in Africa in 2009. So please, Uttara, with your presentation, and you'll be sharing your slides, correct? Oh, also, yes, before we start, I'm supposed to remind people that we need to be putting questions in the chat box. And I think currently the chat box is disabled. So if it needs to be enabled again. Okay, thank you.
Good morning, Rob. Thank you very much. Can you hear me clearly?
Yes.
Okay, great. So let me just share my screen.
Yes, we can see it.
You can see it now? Okay, great.
Yeah.
Let me just make sure it's full screen. Okay, does that work? Excellent, thank you very much. Thank you, Dr. Wardoya, Chairperson of BKKBN, Professor Damanik, Deputy for Training, BKKBN, my co-facilitators, co-presenters, and all of there's so many people who have joined us today on this webinar. Warm greetings from Johns Hopkins CCP to all of you. It's really a pleasure to be able to speak to you about this subject. Family planning in COVID-19, the challenges and coping strategies across countries through an SBC lens. SBC, as many of you may know, is social and behavior change, and that is a critical piece that we focus on in our work at Johns Hopkins CCP. So allow me to start off with an image that was taken from factors affecting the use of essential health interventions. This was presented at a recent GFF report from Zambia, and I think it sort of nicely summarizes some of the demand side factors and affecting family planning. The movement of restrictions, lost income, and concerns about COVID transmission and how these are manifesting alongside supply side factors. In the introduction, a few of these were alluded to, and I think it's important to recognize how these fit together, the demand and supply side. Demand generation is one of those things that high quality SBC is used for in the field of family planning, along with supporting service communication, improving provider behavior, creating a supportive social normative environment, and making sure there's follow-up and ongoing use of contraceptives. SBC can be very responsive to a local context, and it always has to work to engage communities and co-create solutions in difficult times. COVID is one thing that has come up as a challenge right now, but it's not that challenges have not existed before, maybe not on this scale, but many of us working in the area of family planning know that challenges are a way of life. But co-creating solutions with communities is critical for demand generation. And in the time of COVID, it's starting to look very, very different. So we need to recognize that these factors are emerging in a broader context that impacts communication and behavior change. And of course, we need the supply side to be in place if the generated demand is to be met. So what is the current context? Where are we now? It's a challenge. We know people are consuming a lot of information, and in a time when we remain in our houses, we are consuming information on every available platform. what we don't know what is true, what is not. There is an overwhelming amount of information and an equal number of rumors and misinformation, and oftentimes it's difficult to separate fact from fiction. And in all of this, it's also leading to a heightened sense of fear among people, fear of what's going on, fear of going to health services, and even fear of the information itself, which may sometimes be delivering very disheartening information and scary information. So it's hard for people to focus on other things when COVID is taking up so much of their mind space. But these other things, like family planning, are indeed very important, which is why we're here talking about it today. There's another interesting angle to this. At the same time, people are also being asked to start or resume behaviors, preventive behaviors. Some of them are old behaviors, which we want to reinforce, like washing your hands. And some of them are new behaviors, which we're asking people to adopt, like keeping distance, wearing a mask. Learning new behaviors is never an easy thing. And this requires effort, communication, commitment, and it's easy to get overwhelmed by too many changes and new behaviors. At the same time, a lot of family planning SBC does have to happen at the community level. And what's happening now? This usually what happens is one-on-one interpersonal communication at community events, conversations between neighbors, family members. Women and girls also get information about family planning, particularly from friends and family, sometimes through religious or community leaders. And in many places around the world, this type of communication and engagement is being severely restricted. More and more information is being shared digitally through mobile phones, digital channels, radio, television. But we know that there are a lot of women and girls around the world who don't, especially in marginalized groups, they don't have access to these methods or have limited access to these channels. So in that context, how do we discuss it? So I'd like to now take us through a few different country examples and talk about how they try to tackle this dual challenge of demand and supply of family planning, and then focus towards the end on some recommendations or suggestions for social and behavior change, demand generation approaches that might be important for countries to consider as they move forward. So I wanted to start with India. The primary tool in India, which was used for their approach, was the mobile phone. It's an enormous country with a very large population, and interventions can't be easily implemented at a national level. I think Indonesia faces some similar challenges as well. So these approaches had to happen in localized pockets and promotion of content through ads and local considerations. First thing they did was to conduct some marketing outreach to really understand how messaging can be used and what are the key issues that are on people's minds, where were the pain points. So from what they gleaned in this research, they discovered two major things. One was the need for information on where to get contraceptive methods when they had problems with prescriptions, chemists were closed, clinics were restricted, etc. Also, a heightened interest on online services for family planning, counseling, etc. So how did this get addressed? The interest was addressed through digital media, so people could call in and get automated content or have a conversation through WhatsApp or Facebook Messenger with providers and get quick feedback. But from a service delivery point of view, they partnered with PSI and identified 6 online pharmacies that offered home delivery and online consultation services and explained the service and provided a link to the website. So these pharmacies had chains across the country, so that's one of the approaches that is being used at this point. Now I want to move to Nigeria, and sorry, I'm a little all over the place here with the geography. I haven't gone from Asia to Africa. I'm jumping back and forth, but you'll see why. I think it's just to illustrate some of these examples in a logical way. In Nigeria, like with many of the countries, they went into lockdown and most of the services were diverted to COVID. Energy of people, resources, etc. were diverted. And then that presented a problem on how to reach the audiences with services and information and messages. one clever idea they had was to embed family planning messages within the overall COVID messaging, wherever it was possible. And they also did the opposite, which is embed COVID messages within family planning messaging. So they call this the dual integration. So it was sort of a no lost opportunity. And in terms of accessing family planning services, people could call a hotline for information on how and where, and advise people. They got advice on how to replenish their methods at the community pharmacy, and they moved to private sector vendors if a public sector facility was not available, because private sector tended to be open more often. It is a short-term fix because people had to pay for the methods, whereas they were free in the public sector services, and the method mix they wanted was not always available in the private sector facilities. But from a supply side, they had to make up some innovative ideas because interstate transportation had stopped. And the national medical stores needed to move commodities to the states, and otherwise they were going to be lockouts. So a lot of interesting lobbying was needed to put family planning on their radar and make it an important agenda item. So lobbyists engaged with the federal and state governments for the movement of contraceptives, identified champions both nationally and locally, and put pressure to get transport moving and continue to make the case for family planning. The Federal Ministry of Health ultimately got a waiver for 3 third-party logistic companies and helped them address the stockouts towards the third phase of their lockdown. So some of the key lessons learned in this is communicating clear information on the need of family planning and using private sector as a bridge was something that was critical. Also, using SPC materials and social media to reach a wide audience mix was critical. Using proven strategies such as advocacy to ensure commodities got where they needed to go. I'm sorry, but there's something that has appeared on the screen. It's not from my end. Can others see it as well?
All that too.
Okay, so I'm going to continue and pretend and ignore it, but I'm not sure where that appeared from. Okay, the other thing was, it's gone now, great. Another approach in Nigeria was interesting, was called the Honey and Banana Digital Platform. This is very innovative. And what they did was combine, it was a digital platform with a call center. It had website, Twitter, Facebook, and other social media. And they were tracking the calls. In the beginning of COVID, more men called asking about how to prevent pregnancy. And then there were more calls on emergency contraception and pills. And this was throughout the lockdown. And based on this, they were able to quickly adapt messaging for COVID-19 as it impacted couples. People were home more, and so obviously there was, a greater risk of unplanned sex, unprotected sex, and unplanned pregnancies. So the messaging was sort of moved towards this is not the best time to have a baby, and this was put out through social media platform and a call center. And the call center agents worked from home during the lockdown, so they would take the calls from home and were able to provide the counseling services, and even assisted with booking appointments for women and their partners for reproductive health services and contraceptives. An interesting addition was they also helped facilitate waiver letters during the lockdown issued by the Federal Ministry of Health for referred clients, and allowed women to access these referral clinics and not be stopped and harassed at checkpoints. This was important because a lot of people feared going out and breaking the lockdown to go and get their services that were needed. Now, moving back closer to you, to Indonesia, I think this is more a recap for those participants who are in other countries joining in, because most of the participants from Indonesia, I think you know this already, and you've done an amazing job. And I was interested and excited to learn about things that have been put in place in Indonesia. When you went into lockdown very quickly, health facilities were closed due to non-COVID patients, closed to non-COVID patients. Messaging said not to visit unless you needed to, and this was similar in many of our countries. People did not want to visit the health facilities because they were worried about getting COVID. And when social distancing came into place, People like field volunteers and workers could not mobilize and visit the communities to talk about family planning. So the innovation on the demand side in Indonesia focused on field workers starting to work in COVID-related response, and family planning was added as one of the key components. And more than 12,000 field workers were registered for an online training for COVID response through weekly Facebook Live presentations in a program supported by USAID. And field workers also signed up 20 volunteer cadres, each accessing more than 200,000. And materials were developed to disseminate through WhatsApp groups, and the cadre was able to contact these networks of women with continuous messaging. Messaging was also done around the use of online delivery and pharmacy services when available, and family planning was also provided through telemedicine. Using car-mounted audio systems with messaging around family planning and delaying pregnancies was another interesting demand generation innovation. This is a picture from one of the, a flyer from the Facebook Live discussion on family planning training in the time of COVID that took place. From the supply side, BKKBN field workers provided condoms and pills for home delivery, and usually these were provided at health facilities and not by the field worker, but they were allowed to provide directly this time, and this was, an interesting example of, trying to innovate during a time of crisis. Messaging for women to ensure the supply was they got was more than one cycle at a time in case they couldn't come back in time and didn't run out. Also going through the private sector for short-term methods. BKKBN now messaging around services for the new normal and what to expect, how to prepare, also that all the family planning services are now available. Sorry, I'm talking a little bit quickly, but I wanted to make sure I got through all the comments within the designated time and make sure that I was not missing out any of the key content. Going back to Africa, in Zambia, one of the key challenges is the main focus of their family planning program, the gap that they had was adolescents 15 to 19. The data there showed that about 60% of girls before the age of 20 had already had one baby. And this is a very key area for their focus. So reaching young people with sexual reproductive health information and services has been a major challenge. And in the time of a COVID lockdown, you can only imagine how much more of a challenge that would be. So they had initially focused on 3 interventions that were working very well. They had adolescent wellness days, integrated family planning into health area counseling in health centers, and that was very, very well attended. And health workers were trained on confidentiality and how to counsel young people. There was also a multimedia campaign. Now, the challenge during COVID is the wellness days, of course, couldn't be held anymore because this required young people to actually come to the facilities. And not coming to the health facility also meant they wouldn't get any counseling from the trained healthcare providers. Collecting contraceptives was also an issue because people were hesitant to come to the clinics. So how did they adjust and how did they change track? The demand side adjustments, they shifted all the messaging to online platforms, and in rural areas where internet access was a challenge, they used community radio and print to keep young people engaged and connected and thinking about reproductive health services. So comic books, pamphlets, radio talk shows and drama, creating new products such as with scripts that were appropriate for the time and messaging, and in the supply side, promoting young people to get contraceptives from community health workers. So this was a little bit of a shift. In West Africa, Niger, Burkina Faso, Cote d'Ivoire, and Togo, it's a 4-country project on how to adapt. And mass media, they had given the uncertainties in service availability in lockdown. They call to action was radio spots, and they changed from see your health provider to a focus on intermediate behaviors for increasing family planning use. And by intermediate behaviors, we mean things like talk to your spouse about family planning, consider which methods you may want to use, and so on. So the couple counseling, couple communication became a big focus. They added some themes on new spots on getting methods at pharmacies to reduce risk of pregnancy. and community engagement activities, including different social accountability measures, which were halted due to restrictions on gatherings. As the lockdowns ease, they plan for bigger events and converting them into smaller gatherings, complemented by intensified online and social media outreach. So everything that was in the work plan for big, large gatherings was sort of broken down and compartmentalized into smaller gatherings. Closer to you in the Philippines, it's been an exciting campaign they've had on COVID, very, very trendy, and using the COVID-19 platforms that have had a huge reach, they have added family planning messages to it. So for instance, there's a daily virtual press conference that they hold, and the family planning messages have been included in that a few times. And each time they were included, they had a bump in the calls, on the helpline calls that they got for POPCOM, which is their population communication helpline. Social media event cards were used to promote family planning in the time of COVID, again, putting them on big COVID-19 related platforms. So these cards are like pictures that help you discuss the topic. And POPCOM has used COVID as an opportunity to have community-based volunteers distribute pills and condoms, which they couldn't do before, and give out multiple months' supply. There's also been a suggestion to have family planning available at the quarantine centers, where people are waiting out there 2 weeks before they can get back. So what does all this mean for SPC, for family planning? We know that SPC can be effective, and it has to be designed with the person at the center of the design. And we need to be strategic, and it has to be well planned. So in this new context, there are a few things that we should keep in mind in designing our SPC programs for family planning, including demand generation. First is we want to ensure messages resonate with our audience's current emotional state. And what we mean by that is people have a heightened sense of fear. They may also be worried about their contraceptive options and other health needs. We can't forget that we're seeing an increased rate of domestic violence and trauma, and many of these women may also have a need for family planning. So all of that needs to be taken into account when we think about how we design and how we communicate around family planning. We also have to provide practical calls to action. And what we mean by that is give them small, doable actions in the context of where and how they are living right now. And these practical actions may change from week to week. So we also have to be resilient and adaptive in the messaging, because as we know, every week there's a new reality. And messages included have to adapt to those new realities. We have to find new ways of reaching people through trusted sources. And we also have to do this while ensuring volunteerism and informed choice. Make sure that those are central to the family planning information and counseling. Recognizing that SPC partners around the world are having challenges with these kinds of messages, how to think about family planning, etc. Breakthrough Action actually has developed a global program of Johns Hopkins and USAID has developed a guide for guidance on social and behavior change for family planning during COVID-19 for SPC implementers, policymakers, etc. And this is available in English, French, and Spanish, and provides some considerations for adapting family planning SPC programming, as well as some illustrative messages grouped by theme that can be used and adapted to different country settings. It also considers immediate needs, but takes into account long-term family planning communication needs to adapt family planning programs. This is a first iteration, and it will continue to be updated and improved as we develop and understand more information. So think of it as a work in progress, and I can certainly share the link to this document later in the chat so people can access it in the language that they choose. Sorry, that went too quickly. So I want to leave you the last couple slides with a few key considerations. While we are thinking about family planning in SPC, of these many are focused on coordination and partnerships. For example, we want to work with existing SPC coordination mechanisms in country, like technical working groups, RCCE committees, to harmonize updated messaging on family planning, ensure that any outgoing communication with locals is coordinated with local service delivery partners, and any changes in contraceptive and commodity availability or facility openings or closures are reflected in the SPC messaging. And the clients have up-to-date information and are hearing the same message from different partners and not getting confusing, conflicting messages. The SPC programs can also look at expanding partnerships with private sector distribution points like pharmacies and drug shops, modifying messaging to direct clients to these service points when public sector services are not available or inaccessible. With this in mind, we can also think about how we can use SPC approaches to work with these pharmacists and kiosk operators to improve their knowledge of family planning methods. Because people may come to a pharmacy and ask that pharmacist for more information, it would be a good idea to have them educated more about family planning methods as well. SPC implementers can also take steps to modify the content and increase promoting the existing telephone and digital hotlines wherever they're available, and other systems that are providing information on family planning, like the 321 IVR service that's available in many countries, which is automatic voice recording that you can listen to. And these family planning messages can and should be modified to include resources and referrals on gender-based violence. And although community engagement is limited, we do need to find ways to reach those who don't have access to mobile and digital channels. And this can be done through community radio, community-based public address systems like you saw in the Indonesia example, as well as identifying new channels and opportunities for communication. And these, again, as we know, are changing from week to week. Another overarching recommendation is to modify content to promote self-care for family planning, including self-care methods like DMPA-SC, as well as fertility-based awareness methods such as LAM or standard days methods. I mean, these are extraordinary times, and they call for extraordinary measures whenever it's possible. And finally, the guidance in that document I shared also provides a set of illustrative messages, ideas for messages that can be adapted in your context. And as noted before, these should be adapted based on what is locally available and what is locally the policy. For example, the guidance suggests options for overall reframing of messages, like shifting messages away from seeing provider to, talking to your partner and, doing things that you can at home. This is not to say we shouldn't continue to ensure that access to facility-based care is there when needed, but rather to recognize the limitations that the audience may have and be facing in accessing those services sometimes. There's lots of messages in there in the guidance that are method-specific and framed to respond to the audience's current emotional state and physical circumstances. For example, increasing their feeling of empowerment and efficacy by promoting a very positive self-care with short-term methods that are not provider-dependent. Also recommends using messaging on empathy for women and girls, making them feel supported, making them feel like they have some agency in this. Promoting confidence in modern methods is something we can do at this time, which helps in managing side effects among current users and therefore reducing discontinuation. We also know that couple communication is a strong predictor for family planning use, and our messaging during this time can leverage that because many couples are spending a lot of time at home together. And this is often not the case when things are quote unquote normal. So this might be a chance for them to talk about family size, pregnancy, what their future looks like for them. So giving them prompts on having these discussions can provide a good foundation for family planning adoption, even going down the line. Lastly, the guidance touches on messages specific to young people's needs for family planning. And I think some think about other areas we can add. Your recommendations after you look at the guidance would be welcome in terms of areas you'd like to see more information and messaging on. But we encourage you to take a look at it and see if that might be useful in your country context. So I might just stop there and leave you with that so that there's some room for discussion and comments. Sorry, that was a very fast presentation, and I apologize for the speed. I will now stop the share of the screen and bring us back.
Thank you very much.
Within my time. Yeah.
Thank you for that nice overview from different countries around the world and how they're dealing with family planning or dealing with COVID around family planning in their countries. I think you identified a couple areas around, first, of dealing with the infodemic that is happening and all the information that's out there and what to believe and what not to believe and how really to get out from under it. So much stuff comes to us, WhatsApp, Viber, any communication source you're getting information. And then looking at how countries are looking at the continuity of services for women and their partners for family planning, whether that's in messaging and looking at new ways of engaging the audiences in this social distancing time, but also the importance of the continuity of the message, that still talking about family planning, the importance of family planning, and then also looking at how people are getting those services. So if you're in social distancing time or facilities are locked down, how do you get those services? So online services were mentioned. Also looking at where in countries that weren't having field workers providing methods. Here in Indonesia, I think in the Philippines also, field workers were then providing short-term methods, house to house. So looking at how to overcome those barriers and do it quite quickly. We didn't have much time when things started to close down and when activity started ramping up to ensure that. We also look at how to integrate those messages. So not just standalone messages, but how to integrate COVID messaging into family planning messaging and how family planning messages can be integrated into COVID-19 messaging. So not just do it on your own, but how do you ensure that you're working for improving the situation, reducing risk around COVID, but also talking about those family planning issues. So thank you very much, Uttara. Thank you very much for all of the presenters. You all stayed within your time frame. We're actually a little ahead of time right now. And we're going into the next part of our webinar today, which is to have our two discussants for today on the presentations. So our first discussant is Professor Gavin Jones. He is Emeritus Professor at the Australian National University. His first job was with Population Council in New York, Thailand, and Indonesia. Then he was with the Demography and Sociology program at the Australian National University for 28 years, serving as head of the program for an 8-year period. He moved to the National University of Singapore in 2003, where his last appointment was as director for the J.Y. Pillay Comparative Asia Research Center. Professor Jones has conducted research on varied subjects in the field of demography and human resource development, in recent years focusing especially on low fertility regimes in Asia, delayed and non-marriage, urbanization issues, and equity aspects of educational development. Professor Gavin will be providing a discussion on Iris' presentation, the second presentation. So please, Gavin, please go ahead.
Thank you very much. Thank you very much, Rob. Can you hear me?
Yes, we can.
Okay. First of all, thank you very much to BKKBN for inviting me to participate in this very important webinar. I will be commenting on a very interesting presentation that Pakari Sananta made. Just before that, because of perhaps my generation, I'm not very good at screen sharing, and so I sent the PowerPoint. Is it possible now for the PowerPoint to be shown?
Yes, putting it up now.
Thank you. Okay, if you can move to the next one, please. I thought perhaps we should just step back for a moment and take a look at what's happening to the COVID-19 pandemic around the world. And if we go back to January, when it originated in Wuhan in China, the epicenter has moved. It moved from Wuhan to Iran. It moved from Iran to Europe. It moved from Europe to the United States. And it's still an epicenter, of course, in the United States, but there's also another epicenter developing in Latin America, countries like Brazil and Mexico. We hope that there is no movement of an epicenter to Asia, but of course, you know, things are very much in flux at the moment. But if you can just look at the table for a moment, there are extraordinary differences around the world in the incidence of COVID-19 and in the number of deaths. If you can just look at the column on deaths per million population, actually the highest in the world is about in Belgium at the moment. It's not there, but you know, the United Kingdom 632 deaths per million, Italy 573, USA 373, Brazil 248, India 10, Indonesia 9, Australia 4, Malaysia 4. These are extraordinary differences. And of course, as I've noted there, we don't know how many cases and deaths are missed in the official figures. But that's what the official figures are showing. Another point that we should take careful note of, though, in the table, if you look at the last column on testing per million is extremely low in Indonesia. And of course, that makes it harder to know exactly what is going on. It's only half as much in Indonesia as it is in India, and of course, India was also way below many of the other countries. So can we move to the next slide, please? So the dilemma that is faced by Indonesia is one that's faced by all countries, and particularly the low-income countries, how to balance the need to lessen the spread of the virus against the need to enable low-income, informal sector workers living in crowded housing to survive economically. A complete lockdown is not going to be the answer. Now, as I mentioned, Indonesia has extremely low numbers tested for the virus. Without a lockdown, the strategy, it seems, needs to be to increase testing and contact tracing with a view to isolating identified cases and their immediate contacts. It's easy to say, but it's not easy to do. And as far as possible, good hygiene, hand washing and social distancing should be supported and promoted throughout the society. Next slide, please. So moving on to Pak Aris's presentation, he made the point that we have to expect that COVID-19 will be around for a long while. We have to find ways of dealing with it, and I agree with that. He emphasized building resilience at the family level, return to basics, build healthy and environmentally friendly lifestyles, spend only on basic needs, improve diet, stop smoking, lessen consumption of meat, sugar, salt, etc., raise consumption of vegetables and fruit. Again, I agree. A key aim should be to strengthen the body's immune system. And, you know, we haven't given enough attention to that in the past, and perhaps with COVID-19, this can be one of the positive things that we can take out of the situation. But the government must also help. The Asian Development Bank has just forecast that Indonesia will suffer a contraction of its GDP by about 1% this year. Actually, the World Bank and the IMF are talking about global contraction of about 6% this year. So if the ADB is right, Indonesia is not going to do as badly as many other countries in the world. But still, a contraction is a contraction, and programs for the poor will be hard to sustain, but this must, I believe, be the key focus of government policy. Pak Aris mentioned some particular programs that the government could adopt to assist the low-income population in this, and I won't go into that now. Now, he focused quite a bit on the demographic dividend, and I'll just add a few comments to what he had to say. He mentioned it's referred to in different ways: demographic dividend, demographic bonus, window of opportunity, and he doesn't believe in distinguishing between them. I think we can distinguish between them. To me, the window of opportunity is the key point to make first, that there is an opportunity when you have an increasing proportion of the population in the working ages. There's an opportunity to have higher or more rapid increase in per capita income, and in that sense, the opportunity of a demographic dividend or a demographic bonus. But there's no certainty, absolutely no certainty, that this opportunity will be utilized. It's often been stressed that the demographic dividend, so-called, can be a demographic disaster if two things happen: if productive jobs aren't available for the potential workers, and secondly, if young people can't complete an education that will yield them good jobs. And there is a real risk that COVID-19 will lead to exactly those outcomes in Indonesia and in many other countries. Next, please. Pakaris raised some measurement issues, and again I agree with those measurement issues. This idea of taking 15 to 64 aged population as the potential workers, and under 15 and over 65 as the dependent population is a very, very rough rule of thumb. For example, you have women's involvement in the workforce can change dramatically. I'm doing a lot of work in Pakistan now, where women are less than 25% of women are in the workforce. If you raise that to 50%, that would make an enormous difference to the number of potential workers. Then, of course, you have young people delaying entry to the workforce. You have old people not dropping out. If I can mention a personal note, if we take 65 as the, above 65 is where you stop being productive. I've ceased to be productive about 14 years ago, and yet I feel personally that the last 14 years have been some of the most productive years of my life. Anyway, that's just one example of the crudity of the measurement. But I think Pakaris's arguments about the demographic dividend went much deeper than that. And so we should focus on the key points that he raised. In the current situation, as he said, the key issue is the need to keep as many workers as possible. Can we move to the next one, please? Keep as many workers as possible in productive employment. The proportion of the population who are potential workers is not the issue. A second key issue is how to help young people complete their education so that they can find suitable work. So what proportion of the population is in arbitrarily defined productive ages, or indeed in arbitrarily defined ages of entering the workforce, is not the issue. So the demographic dividend is not a relevant concern in the current situation. And, on that point, I agree with Professor Aries. Next, please. Finally, on the issue of building social responsibility, his presentation stressed that BKKBN can help build social responsibility to limit the spread of the virus. And one point I'd like to just make here for us to think about, there are important issues of intergenerational solidarity here. The virus infects people across the age range, but older people are far more likely to die when infected. I could have shown you some figures on that, but I think everyone's aware of that fact. So younger people must take steps to limit the spread in the interest of saving lives of the elderly, even though they themselves are unlikely to die from COVID-19. But young people's future is likely to be severely compromised by the steps taken to limit the spread of the virus. And older people must realise that a complete lockdown to limit their risk of death will seriously affect the well-being of young people trying to make a living and raise a family. So these intergenerational issues are very important, and intergenerational compromise is, I think, an essential element of COVID-19 policy that we need to keep in mind. Well, Mr. Moderator, I believe I've used up the available time, so I'll leave it there. Thank you very much.
Thank you, Gavin, for your feedback and perspective on Paris's presentation. I think that gives us some food for thought as we look into questions and in the discussion period coming ahead. Our second discussant is Dr. Iwan Arian. Iwan received his medical doctor degree from Universitas Indonesia and a Master of Science in Epidemiology from the University of California, Los Angeles. Now he is senior researcher at Universitas Indonesia and doing many studies related to reproductive health, public health, nutrition, and COVID-19 epidemic. Some of his previous works include study of long-acting and permanent methods in East Java and Nusa Tenggara Barat, national vaccine acceptance, health and nutrition in Jakarta, urban slum. He is on assignment to Indonesian Presidential Office for the modeling and monitoring of COVID-19 epidemic here in Indonesia. Please, Pak Iwan. He will be discussing Uttara's presentation. Please, the floor is yours, Pak Iwan.
Yeah, thank you, Pak Rob. So, and then thank you to BKKBN for this opportunity. Okay, I will share screen. Okay, let me put it in the. Okay, everybody can see my screen?
Yes, we can.
Okay, thank you. Okay, so actually I will begin with the social distancing policy in Indonesia first. And then I'll continue to the comment on the Uttara presentation. So, as we already know that in Indonesia, there is a social distancing policy. And then we have the PSBB, or in English, it's Massive Social Distancing Policy by April. And by March, sorry, not April, this should be March. Okay. And then we could see actually there is a decrease in the population mobility in Indonesia. This is, I use the Google cubic mobility data to measure the population mobility in Indonesia. So the red one it means that less population stay at home, and then if it is brighter red, and then blue it means that more population stay at home. So we could see actually the social distancing policy. Sorry. Okay, we could see actually the social distancing policy has an effect on the population mobility. And also, it will have effect on the economic and also to the essential health services, including family planning in this case. But the effect is real about the social distancing. This is if we see the effective reproduction number. This is the number to measure the transmission of COVID-19. And we could see here, after the social distancing policy around here, we could see the decreasing in the effective reproduction number, or the transmission rate. We could say the transmission rate of the COVID-19 in Indonesia. And last couple of days, the reproduction rate is the effective reproduction rate. This is the effective reproduction rate of the virus, of the COVID-19. Is still 1.12. What does it mean? It means that one of the infected person infected more than 1%. So it means that actually the epidemic is not controlled yet. And according to WHO, to lose to loosen the social distancing policy, the RT should be less than 1 for 2 weeks. But in Indonesia, it's still 1.12, and then the government already started loosen the social distancing and introducing new normal. As Prof. Aris already presented, because it is impossible to make long social distancing in the country like Indonesia. So now, new normal is introducing, but the question is how to ensure the population, the community, compliance to the new normal, to the preventive measure to control the COVID-19 epidemic. Okay, then we go here. This is the difficulty. And this is related to the communication. And then here is one of the survey from Save the Children. They are the first who did the survey in the population using the phone and using the online survey. And then this is the risk perception. The risk perception is only 1 of 3 believe that the virus cannot survive in tropical climate. 30% believe that the virus cannot survive in tropical climate. And then about 60% or 2 in 3 respondents believe that they are not at risk at all. And then 9 in 10 respondents confident their immune system are strong enough to fight the virus. This is the risk perception of the population, of the community. So we can see that actually they think they are not at risk to get this COVID-19 infection. So they are doing the social distancing, they are stay at home, they are using masks because the government asked to do it. Of course, some have the good risk perception, but most of them have this kind of risk perception. So then what is the challenge? Okay, this is the challenges for us because now this is a dual challenges for the family planning and then for the prevention of the COVID-19. So right now, as Utara already presented, that many people focus on the COVID-19 information. It's either the right information or the wrong information. So there are less attention to other information like family planning. So then the challenge is how to make this community put back their attention to the family planning information, and actually not just family planning, but other health-related information, not just to COVID. Yeah. And then the second challenge is how to communicate to these people also about the risk to get infection of COVID-19, which is in current situation is still high. Remember that our effective reproduction number of COVID-19 is still more than 1, which is according to WHO, it is not, the epidemic is not controlled yet, but we already loosen the social distancing. So this is a dual challenge. So how to communicate this one? How the SBC could help to have a communication about the risk of getting infection while people going out, and then also the people can go out to get the essential health services and family planning, but also avoid the risk to get the infection. I think that's the main challenge for us to give the communication to the population right now. I think I stop here, and then we could continue in the discussion later on. Thank you.
Thank you, Pak Iwan, for that for the discussion points. I think very interesting in looking at where communication can have an effect overall in terms of based on the evidence we have here in Indonesia. So another food for thought as we go into the discussion period, which we're going to start now. So we had questions in the chat box for the last hour or so. We have a lot of questions, and I'm going to through and ask certain panelists on those questions, and the person can take the lead. If others feel they would like to answer, have something to add, that's also possible. Not a problem. So for the first question we have is for Professor Damanik, is how is the involvement of CSO in the family planning program in Indonesia, particularly during COVID-19 outbreak? And I think we'll just go one by one.
Okay, thank you, Rob. Thank you for the question. So, family planning services in Indonesia is the result of a triangular contribution among government, private sector, and community. Civil society organizations representing community play an important role in the demand and supply sides of family planning programs. They have their particular vision and interests that are aligned and complementary with government's program. Some put more emphasis in the communication and advocacy strategy, but others, such as the faith-based organization, concentrate on gaining collective agreement on family planning and provide the services at the same time. So during COVID-19 pandemic, they are still consistent to contribute to family planning program together with the government with certain limitations, of course.
Thank you. For Pa Aris, a question, what if efforts to change the term new normal into a language that can be easily understood by all levels of society? Because some people think that new normal is normal again, and this is a fatal alias. It must be straightened out. Pa Aris?
Yeah, thank you, Rob. I think I completely agree, but that we have to think about a new word rather than new normal. Maybe one of my friends suggests new norm, norma baru, and I read in the chat new behavior. Yeah, I think I agree that, and then we have to find new words so that we don't expect that return to the new normal. I completely agree, Pak. Thank you.
Thank you, and I think words are context focus on everything. So let me go to Uttara. Here's a question. How gender analysis can be based to formulate, oh no, I'm sorry, I have the wrong one. How to ensure that there's gender equity in our response towards this pandemic?
Thank you for that question, Rob. I think it's a very, very important question. I might have touched upon this in the presentation, but we do need to ensure that we're not just being gender equal, but also equitable, to make sure that women and girls get more than the necessary, more than what they're getting now in terms of access. We talked about the modes of reaching them, like if things are put up in channels that they do not have access to, like mobile phones, because in a family, the person controlling the use of the mobile phone may be the man, or you might have situations where the timing of certain radio listening happens as a family. She may not have specific access. So there's a number of ways services and health promotion may not reach women. So when we design programs, it's absolutely important to keep that in mind. So anticipating some of those challenges would be the first and most important way to make sure the programs are gender equitable, recognizing that that is an issue and building that into the design of the program.
Thank you, Uttara.
Yeah.
And sorry. If the discussants would also like to chime in on answer any of those three questions, please feel free. Okay, we'll go on to the next question.
Rob, I just wanted to, sorry if I may, I just wanted something I didn't get a chance to say during my presentation. I just wanted to thank PKB from Sulawesi and West Java and Lampung and Riau for the photos in the presentation. We were running around trying to get a lot of good photos and appreciate them getting us some great photos.
Thank you very much, Uttara. I think that is very appreciated to the PKB here, the field workers working in Indonesia. throughout Indonesia, and we did ask for photos from them, and we did get them from those PKB. So thank you very much to the specific ones, but thank you also to all the PKB Indonesia, many that are on this call right now that are on the forefront of COVID-19 and being a first responder to this. So thank you very much. This next question is going to be to all of you, I think, to the three panelists and discussants on this. According to the panelists, what is the most effective way to increase public confidence in the government, especially related to public health during the COVID-19 period? And this is in the context of there's a lot of distrust on government, and if government's the main player in promoting reducing risk, how do we ensure that there is confidence in the government? What are some strategies that might work? And I would open that up to all three panelists and two discussants.
Rob, may I try to answer that question?
Please.
Yeah, to me that everybody has to work together. The government, the community, the individual has to work together.
Okay, thank you. Others?
Wait, I haven't finished. I think everybody has to work together. The government, the community, and the individual has to work together. I think as individual, we have to help each other to create the new normal, new behavior, or new norm, or whatever. This is new thing. We cannot go back to the old one. So this awareness, like our friend Utara also mentioned that, and Pa Iwan also mentioned that the awareness is still weak in Indonesia. So that everybody has to bring this and then avoid sending false news, hoax, and then that's the thing that we have to avoid that one, and what we call social responsibility. I think that's what we should do. Yeah. Thank you. That's all from me.
Thank you. Uttara or Padamanak or the discussants, Gavin and Pa Iwan?
Yeah, I think I agree with Professor Arisananta just mentioned. We should work together, right, to promote and to educate and to advocate, give an advocation to all people, not only in the city but also in the urban areas, using this kind of IT things, because this is a new situation. This pandemic is new for all of us. We haven't had this kind of experience before. The last pandemic situation I think it happened 100 years ago, and since that we haven't got any it's a long time ago then. So now or hand in hand between the government and then the local organization, to encourage, to support all the families. That's my point, Rob.
Thank you.
Rob. Yeah, Pak Rob.
Yeah, go ahead, Pa Iwan.
Yeah, I think I could add that there should be a consistent message from the government, because currently we have seen there is a not consistent message between ministry and then between the other policymaker that make the people confused. Which one is right, which one is not right, which one should be done, which one should not be done. So I think consistency is important, and then also should focus to the practical things, like if you say it social distancing, how the people like in slum area do the social distancing, and then wearing masks, how many masks they should have, because if you are going out, you are trading something, and then you are the motorcycle driver, the Gojek driver, if you only have one mask, then it will be wet, then you will not be use it again. So it should be, the message should be practical for all people, not just the people that have nice office and then nice house and then nice income. Okay, that's from my side.
Hello. Can
Yes,
I?
go ahead.
Yeah. I think Ewan has made essentially the point that I was going to make, so perhaps there's no need for me to speak. But I think the consistency of message coming from government is very, very important. And I think without mentioning countries, I think we can note some of the countries where the pandemic is worst, where that consistency of message coming from government has certainly not been there. It makes people very uncertain and confused, and it's very important that all parts of government are on the same page on this one in the messages that they give. Yeah.
Perhaps I can add one more thing, Rob. I think I agree with everything everyone has said. One more thing to add perhaps would be to build trust. We have to have transparency, and we need to also admit when things we don't know. So I think that would give people a lot of confidence when we know that this is a constantly changing pandemic. Information changes on a day-to-day basis, and that they can trust their leaders to give them the correct information as they have it then. And when things are, a strategy doesn't work or something, to be able to admit that and say, we tried this because of this, and now we're going to change our approach, would give public a lot of confidence to know that the leaders have their best interest in mind and will do the right thing and be honest with them. I think that will build a lot of trust.
Thank you. I totally agree with all the respondents. I think one of and kind of goes through all of them, is that the consistency of the information and having a one voice from government and not a number of information coming from a lot of different places, but one that is consistent, that is standardized and the same, and like Uttara said, is able to change if needs to. Admit that what worked didn't work, and now we're moving on. When we first started the pandemic, we looked at masks. Masks, they said, don't wear a mask if you're not sick. Now everybody should be wearing a mask. So things change. Thank you. This next question is going to go, I think, to start with Iris, is how does this pandemic affect the productive age group? And you can interpret that as you will.
How does it affect the productive age group? First of all, what is productive age group? Is 15 to 64 the productive age group? That's my question. Because many people aged 15 to 64 are not productive. In Indonesia, people are employed but not productively, low-income people. And people live in subsistence. They don't have skill. Their health is not good. During the COVID-19, we hear that many people aged 30 and 40 are infected with the COVID-19 and they suffer. That means that they are not in very good health. So when you ask about COVID-19 affected productive people, first is that what age? I don't think that we have to define by the age. Productive can be, everybody can be productive. Unproductive can be everywhere. And this question is also the one I not happy with, because the question is very related to economic growth. So if COVID-19 attacked the unproductive group, is that good? If people are poor, 50-year-old people are poor, they are not productive, their skill is not good, and they are attacked by the COVID-19 and they die. It doesn't affect economic growth because they are poor. So if we think about economic growth, then we shouldn't care for the low-income people, those who don't have skill, because if they are attacked by COVID-19, it's okay. They don't contribute to economic growth. So we have to think differently rather than talking about economic growth, productivity in terms of economic growth. We talk about productivity in terms of welfare, well-being of the people. That's not only income, but happiness, health, education. I think that's my comment, Pak Rob.
Thank you. Any other additions to that? This one is for Damanik. I learned that BKKBN organized family development along with family planning program. How this program is developed so far?
Thank you. BKKBN has a vision to realize Indonesia quality family. It is part of a national agenda to enhance the quality of Indonesia human resource. So the program highlights desirable character building and strongly adopts inclusivity. It embraces different socio-demographic background of program beneficiaries. The program goes from first 1,000 days of life until providing long-term care for the elderly. In Indonesia, families share common values that are held in the highest esteem. It is our precious social capital that needs to be highly preserved. So the programs are translated to empower family and family members to contribute to the achievement of our national development programs. That's my response, Bob.
Oh, I always do it the wrong way. Sorry, my mic is now on. Thank you very much, Professor Damanik. Anybody else would like to add to that on the panel? It was very specific for BKKBN. Okay. This one I think I'll open up to everybody. It says, without a clear end to the pandemic in sight, what does a favorable policy environment for family planning program look like in this new normal era? So without a clear end to the pandemic in sight, what does a favorable policy environment for family planning program look like in this new normal era?
In the new normal or new behavior, we have to do that to implement family planning. We have to be creative so that we could continue providing contraceptive use in the affordable way, but preventing the spread of the virus. If we ask questions about that, we have to work together. We have to be innovative. We have to be creative. This is still new. There is nothing in the textbook about that. So if we are making mistake, that's very human. But we learn together, we work together. And the most important thing is that we have to realize that contraceptive use is one of basic human rights. So when we think about low-income people helping the basic need should include contraceptive use. That's my comment, Bob.
Thank you. Others?
Yeah, Pak Rob.
Please go ahead, Paiwan.
Yeah. Yes, I agree that actually we have a long way to go to combat this COVID-19 in the world and in Indonesia. We just doing the exercise on modeling of the COVID-19 in Indonesia, and then it showed that actually it is not going to end very soon. So it means that we cannot stop the essential health services, including family planning. So the essential health services should continue, should start again, and should continue. And the challenge is how to make the people and also the health provider not infected with COVID-19. Actually, there is a new publication in Lancet that show actually the preventive measures like washing hand with soap and then using masks and then physical distancing have a great effect in reducing the risk of transmission of COVID-19. So actually, if the preventive measure is done correctly, and then plus the using of PPE in the health services, actually the risk of getting infection become minimal and it's controllable. The only question is, could the health provider, could the community do it consistently and correctly? Because if they do it correctly, they do it consistently, actually we can reduce the risk to get infection in this situation.
Thank you, Pak. Others?
Yeah. So I'd like to add a little bit of. I agree with what Professor Aris mentioned. We should creative, more progressive in the developing the programs, and not just wait for the development, to find the finding out of the vaccine, for instance, So in practical aspects, I would suggest that the maintain of the health status of the people maybe play an important role. These can be achieved by, what we call a balanced diet, So why this balanced diet? To maintain our health, to stimulate the immunity is very important, because the infection causes by the virus, there is no medicine at all can be used. Not like a bacteria. Bacteria can be treated by the antibiotics, but the virus, it is based on our immunity. So how to maintain and how to increase the immunity of the people is very important to be understand by the people. Yeah, that's the thing that I want to address about the importance of the maintaining our health. Thanks, Rob.
Thank you. So what personal responsibilities we have in this new era also. Thank you. Here's another question. It's been months since all schools are closed. In long-term perspective, what effect it would have on our young generation in the years ahead? Because no school means less interaction with people their age and less outdoor activity. So overall, how is this affecting with the closure of schools and kids not able to get together? I say on all parts of that area.
There will be a new generation, Pak Rob, and people often ask that question, can we go to the old one? I think this is a challenge. I do not know the answer now, but this is the challenge for us. There is no other way. We have to go this way, and then we have to find new method how to educate people. In some places, we could have online education. We have the webinar now is a new norm. With this webinar, we could go to every country in the world and all places in Indonesia. So I think it is our job together. It's not yet here, but we have to be perseverant and work hard to find the new ways or new behavior, new technology. It may be simple, maybe advanced. And the answer may not be for everybody. For example, with the stay at home. For those who can afford to stay at home, please stay at home and work from home. I know not everybody can do that. For those who work in the formal building, please open your window more often, for example, more ventilation, and reduce the use of aircon. Just example. Maybe also that you have sun break, not coffee break, but sun break. Maybe over 2 hours you go out to get the sun. Maybe that's for those of you. Sun break. Yeah, and for those of you who have to work outside the house, outside the home, reduce the crowd, reduce the contact for other people. But for those of you who don't have to go out, would you delay going out? So the answer is not for everybody. And I'm thinking that maybe we have to fasten to create screening. Like now when we go to hotel, public space, we have screening for terrorism, for weapon. But can we create more now? Screening for virus. Once you are free, we could go to the building or place freely, we can do whatever. I think that's my small contribution.
Thank you. Others on the panel? Uttara, Gavin, Iwan? How this will affect our generation of kids?
Okay. Let me just mention one point. The online learning, of course, is something that we have to be focusing on as much as possible, but at least from the recent experience in Australia, it's been found that the more disadvantaged groups in the society suffer from having online learning because they don't have access to computers and things like that. So, online learning works well for the better off groups, but actual physical presence in the classroom tends to be very important for the more disadvantaged groups. So I don't know what the answer is to this, but it is a major issue, and I think it would also apply in Indonesia.
Thank you. Uttara, were you about to say something also?
Yeah, I was just going to say that I don't think it's an easy answer either, but it's given us an opportunity to really do an unprecedented evaluation of online learning, which an experiment which may not have ever happened before the lockdown. So it allows us to truly understand what is and isn't possible. Maybe there's plus sides to making education more accessible to some people who didn't have it before, by learning from how online learning could work or not work, and where it does and doesn't. So I think it would be important for us to learn and critically analyze the situation and see what implications it might have for us as we go back into the way things were before.
Thank you.
May I add one more about the access of online learning to the remote area? I think it's a very good business opportunity. The business has provided handphone everywhere to the remote area, but now make the people from everywhere Indonesia can contact people everywhere Indonesia and even the world can make a video call cheap. So now I think it's a challenge for the business people now. How can they provide access to the online technology even to the remote area? So this is a good opportunity for all of us who have business spirit to create technology or product so that people can have online learning from everywhere in Indonesia and in the affordable way, like the availability of handphone. Thank you.
Thank you for that. Yeah, I think it looking at how to ensure that we get that education to everybody, even with those with less access to internet and online services. Something to think about as we move forward. And there was a question, I think you just answered it. What are the economic advantages or possibilities through in this new normal? And I think you kind of answered that as this is the new opportunity on the financial side. Thank you. There was a question on, has there been any observation on the access to services from private? I would assume that the services through private is declining more. Is that the case? So the family planning services or health services through the private sector compared to the public sector? And I'm guessing this is in Indonesia, but also if we have perspectives of other countries. Please, panelists.
Maybe I can just kick off, Rob, just to say that from reviewing the country examples, I don't think there's been an actual evaluation done, but it does look like private sector has a great deal more flexibility, and therefore they've, in terms of short term, they've tried to ensure that the private sector has been used. So their ability to deliver, to get to the last mile is much more. So that's probably why the private sector has stepped in, but it certainly would be interesting to find out more about the actual numbers of where they were used more and what has been the effect of that.
Thank you, Uttara. That's a good observation. Other observations, Pak Damanik, on BKKBN and working with the private sector on midwives. I know looking at getting PPE to them, etc. So you are working on the private sector also. Is there any information or insights you have on how private sector services have been affected?
Bob, this is a general question on the role of private sector. Private sector is always talking about benefit, about profit, and that's not wrong because they are concerned about profit. If it doesn't make profit, they will not come. But for policymaker, there are also things which are not profitable for the private sector, but important for the people. For the things like this, that is not profitable for the private sector, I think the government has to intervene. Or another way is how to make private sector interested in this seemingly non-profitable way, like long-term contraceptive use. Can it make it profitable for the profit sector, for the private sector too? Otherwise, the government has to intervene and doesn't let on the private sector. Same thing with the technology. I believe that private sector can have ideas to make profit from the situation by providing online technology for people to study, for business, and so on in the remote area. The same thing for the contraceptive use. If we persuade, if we give a facility for the private sector to develop their initiative, how can they provide many things that we need? I think that's good. But the main thing I emphasize is that private sector concern is profit, and there's nothing wrong. But we have to work that if they are not interested, then we have to go in. The government has to go in or make incentive for them to go in. Thank you, Pak.
Thank you. Any other responses? Okay, we'll go on to our next question. Lately, due to COVID-19 outbreak, we hear the increase of pregnancy numbers in some areas in Indonesia, but in the other side, we also hear about increasing of domestic violence. How is BKKBN coping and managing these issues? And I will open this up, not just specifically to BKKBN, obviously, Pak Damanik, if others have insight also, but please, Prof.
Yeah, thanks. BKKBN, during this pandemic, has increased the awareness through advocacy by collaborating on family planning issues program services virtually, right, with private sectors and many organizations. And moreover, provincial BKKBN and representatives in the 34 provinces have improved family planning program services as well by providing contraceptions at the several service points. As I mentioned earlier, that the BKKBN has also collaborated with the Johns Hopkins CCP and the COVID task force with the support from the USA. The COVID-19 prevention communication is conducted within outreach, public communication, collaborated again with the private sector and social media. Also, we spread the key messages on the COVID-19 and communicate through online mechanism, and this benefit our cooperation with private sectors. That's my comment.
Thank you, Prof. Other insights from our panelists on how also dealing with the gender-based violence? Okay. This is, I think we're taking about 2 more questions. I think I'm told time. Okay. I'm trying to find. Oh yeah. So this is a question. During the pandemic, what was the most appropriate contraception used? Do we see a difference in use of contraceptives through this time, and why would that be? And I'm going to open that up to all the panelists.
Yeah, for the Indonesia case, the popular contraception is a condom, since there is a limitation, for the transportation, and then the pharmacies and also the shop are closed to sell, the contraceptive things like injection. But BKKBN, has an initiative to provide not only a condom, but also the injectable and also pills, work together with the midwife association. So our staff at the field officers, the PKB, also play a significant role in this kind of things. They bring and they accompany the midwives of the people who want to get to receive a service to the midwife home, for instance, to get the service system. So we try to provide all the contraceptive methods, like IUDs or the pills, in time, and also about the pill. We provide the single dose, not double dose for the injection things as well.
Thank you. Others, in their experiences, have seen any more popular methods than others? And I'm guessing we're looking at more on short term. Long term, they weren't changing, but short term, I guess easier to.
Yeah,
easier to
we have to think about the long-term contraceptive, but we have to we have the incentive for the private sector to provide long-term contraceptive during this time of uncertainty. This is very good because they don't have to come to the clinic too often. Yeah. So
I agree. I agree with Professor Aris mentioned about the long-term method. But since this is this is a new experience, we just begin about this stay-at-home policy in March. So until now, it's still, we learn. We look at first what will be happen, So the strategy also, we try several strategy first, because not only for us, the case is not only from the BKKBN, because others, the environment, the other policy from the government, like the transportation, public transportation, and the policy about the shop things and the office and the factory, to which is a cause, unemployment also influence about this kind of situation. We at the BKKBN has conducted a kind of research actually, but this is not. I mean, this is virtual. This is not primary data. We just use the online research. Online research. What kind of contraceptive methods are popular among the people? We also ask them, about the frequency, the frequency of intimate between the husband and wife. Our data shows the survey is the participants of the survey is in total is about 24,000 respondents throughout Indonesia, but is worth to be noted that it is not representative for the Indonesia case, but this is kind of a survey, online survey then. So the frequency during we compare the intimate frequencies between the husband and wife. The data show is decreasing actually, during the COVID period. So it is hope then, that there is no pregnancy later on, But from the method of contraception, due to the limitation in transportation, as I mentioned earlier, and this is a new kind of situation, so people are still waiting what is happening, right? What thing and other things, But now we can make and reformulate about the strategy how to involve this kind of situation. Thank you.
Thank you, Prof. Uttara, were you about to say something also?
Yeah, I just wanted to add that I think in just looking at different country examples and at both the previous responses alluded to this, long-term methods, this may be a good opportunity to promote long-term methods in the future, where people understand there will be disruption of services and it may be safer to be on a long-term method. However, given that this was something that came up very suddenly, people may not have had the opportunity to switch to a long-term method. So currently what we are seeing are trends where the short-term methods are more popular, methods that don't involve human contact, things that can be dropped off like pills and condoms, are currently more popular. And in some cases, even the rhythm method and other things are being promoted where the contraceptives are truly not being made available.
Thank you. A good point on that, on the self-care type, what you mentioned a little on self-care and probably self-injectables too. So I think that's going to wrap it up for this webinar. I would like to thank the panelists for their presentations and the insights you've provided from those presentations. To the discussants, thank you very much for your time to provide perspective to the panelists and presentations, and also the kind of the feedback into that so that we could have this rich discussion. I feel that this webinar was very, very comprehensive in looking at how we can work within what we're given in COVID-19, in the new normal, the new normals, as we're now starting to say, with Pa Aris recommending that. And I think that's a good idea. But how programs are able to function and still look at the continuity of services, continuity of messaging around family planning. We're dealing with disruptions in supply side. We're dealing with disruptions on the demand side. But we, at the core of it, as Professor Aris mentioned, family planning, contraception is a human right. It needs to be at the top of the list, and we need to ensure that that happens during this time, and whatever that means. We're learning, we're moving ahead, and we'll probably take a couple steps back. We'll go forward. These lockdowns are easing, but we're seeing in countries where the lockdowns are being reimposed. I think Utra was telling me yesterday that in her city of Chennai, they've reimposed the lockdown a couple of days ago. So we know that's going to happen. We're not going to be free of this until there's a vaccine. So how do we take these recommendations, these ideas we've learned today, and start putting them into practice in our programs, in our countries around the world? I think BKKBN is a good example of what's happened so far and how they moved quite quickly and how to ensure the supply side of the equation, ensuring that we have the methods, but also at the same time, how do we ensure the demand side? How do we do the counseling? There were a number of questions around counseling that we didn't get to, but really, how do we continue that counseling to women that want it, that want the information? And then finally, how do they make an informed choice on what they want? So again, thank you to Professor Aris, to Padamanik, to Uttara, to Gavin, and also to Pa Iwan for your time today in sharing your experiences and recommendations and lessons learned. We really appreciate it, and job well done. Thank you very much.
Thank you very much, Pa Prof. Thank you, everybody.
Thank you.
Thank you, everybody.
Thank you.
Darcy and Rob for very interesting and fruitful discussion on the topic. I might not have further conclusion as it is very clear and straightforward. And I must thank Asian Population Association, Johns Hopkins University, and PPD member countries for their support. And I would like also kindly invite Mr. Adnene Ben Haj Aisa, the Honorable Executive Director of PPD, to give his statement or some comments. Mr. Adnene. He is the Executive Director of PPD.
The PPD Secretariat is attending this seminar, I think. You can see. Can the admin unmute?
Good morning.
Morning.
Is it okay? Do you hear me?
Yes, we can.
Yes.
Okay, thank you. Thank colleagues, friends from BKKBN. Thank panelists, moderators, discussant. This is a very good opportunity, and thank you for giving me the floor to say a few words in this important webinar. I must start by congratulating BKKBN and Johns Hopkins University for the topic chosen to discuss on public health and economic development in this COVID-19 situation. We had a very interesting and informative presentation made today, and had offered an excellent opportunity to learn about different experiences and strategies. I think this is will contribute, in the information sharing among our stakeholders and also among the partners. We had learned from also the Indonesian experience of family planning, which is one of the leading country in family planning. And Indonesia is one of the founding member of PPD, and it has been a success story in family planning since 1994. And we really appreciate the efforts that the BKKBN is doing during this COVID-19 to ensure contraceptives, family planning services to all the population and also to the community. As you know, information and knowledge sharing is one of our main interventions in PPD to promote South-South cooperation among PPD member and also non-member countries. This is done within the spirit of solidarity and common interest. I think I must say a few words about the COVID-19, that this pandemic has confirmed that health is not a cost. Health is an investment. And investing in health and education and creating job opportunities is crucial for demographic dividend, as it was clearly explained by Professor Aris. The post-COVID-19 will need more national unity, but also it needs also global solidarity to build resilient economies and healthy communities. We don't need only to have health system, but we need to have intervention and contribution from all national partners, NGOs, media, and all. And I think the post-COVID-19 will offer an excellent opportunity for countries to review and assess their health system, because that should be a priority for all nations, whether from the north or from the south. And I'm confident that South-South cooperation will play a leading role in sharing and build the capacities of different countries, whether developing PPD member countries and also developing countries. I would like to thank by these few words, and thank you for giving me this opportunity, and wish you success, and hope that we will have other opportunities for sharing this information. And thanks for BKKBN. Thank you.
Thank you, Mr. Adnini, for your statement. Warmest greetings from our chairman of BKKBN. We wish that the webinar will build a network with different partners and experts to continue online sharing of best practices under these restrictions of movements and gathering. So this meeting can also be accessed through live streaming on YouTube and Facebook, and all of the material presentation can be downloaded from the chat box. We would like to kindly invite you again in our next webinar with the following announcement. For further information on the upcoming webinar, please visit our website at citc.bkkbn.go.id. As our appreciation of your participation, please grab your certificate by filling the Google form. You will get your certificate written on your name automatically after completing the form. The address of the link is as follows. You may take a picture on that, and we also put and write it on the chat box. And for all resource persons, we will send the certificate to you by email. Finally, on behalf of the chairman of BKKBN, I would like to thank for your valuable contribution and hope to see you again in November 17, 2020. Stay safe.